My name is David Lloyd. I'm a fourth-year medical student at the University of Buffalo. I wanted to present a brief case report on a patient I saw. This patient was a 52-year-old female. She had a recent history of a motor vehicle accident. During the accident, she was a front seat passenger. The vehicle had traveled off the road and collided with a telephone pole. In the incident, there was no airbag deployment. She was wearing her seatbelt. She recalls her head colliding with the front windshield, as well as a collision with her left arm with the front windshield, but did not recall if any other body parts collided during the accident. She reported a brief loss of consciousness, but no blood loss. Following the collision, the vehicle was not drivable, but she was able to walk back to her home without incident and sought no emergency care. Since the collision, she's had complaints of neck pain localized between her shoulder blades, lower back pain, pain in both lower extremities, right upper extremity pain, weakness, and tingling. She finds that her right upper extremity pain is worse when using her right arm. However, the pain is minimized when she returns the extremity to a resting position. She's noticed that the medial right forearm in the fourth and fifth digits have intermittent tingling, weakness, and pain, and that this pain is worse with elbow flexion and when she applies pressure over the area of the elbow. Since the accident, she's had new onset headaches, insomnia, and tinnitus. These headaches are experienced in the temples bilaterally, which are reported to be severe in nature. Headaches are associated with photophobia, phonophobia, and nausea. The headaches are aggravated by reading, relieved by resting and sleeping. She also recently complains of forgetfulness, low energy, decreased mood, poor, dizziness. She, however, has had no incontinence, chest pain, shortness of breath, or abdominal pain. She reports having no prior medical conditions, no prior surgeries, and takes no medications on a regular basis. Aside from this trauma, she's had no previous traumatic incidents and no prior injuries. On physical exam, she was found to be in no apparent distress. She was alert and oriented. Times 3. Her pupils were equal and reactive to light and accommodation. Her extraocular movements were intact. She was found to be with regular rate and rhythm of the heart, no murmurs or rubs. She had a normal S1, S2. Radial pulses were +2 bilaterally. Her lungs were cleared of auscultation bilaterally. There were no wheezes, rales, or rhonchi. The musculoskeletal exam, she was found to have strength of 4 out of 5 in the right upper extremity. And of note, her grip strength was 25 pounds and her pinch strength was 5 pounds. This was compared to the left upper extremity, where the grip strength was found to be 50 pounds and the pinch strength was found to be 12 pounds. The strength in both lower extremities was 5 out of 5 bilaterally and was not quantified. She was noted to have a positive Tinel's sign at the right elbow. Test for Tinel's sign at the elbow involves applying pressure over the cubital tunnel. The patient had previously noted that when she applied pressure vaguely in this area, she would reproduce the tingling. During the physical exam, we were also able to reproduce the tingling, and we were able to quantify the amount of pressure required for this. We found that 8 pounds per square inch produced tingling in the fourth and fifth digits. In addition to this, the patient was found to have a positive Sperling's test of the right upper extremity. To perform this test, the patient was asked to turn her head to the right side. She was asked to produce a slight flexion, and pressure was applied cranially. And in the process of this, pain was localized to her arm and upper elbow. She was noted to have atrophy of the right thenar muscles, most notably the abductor pollicis. And on cervical spine range of motion, she was noted to have flexion of 25 degrees and extension limited to 4 degrees due to shoulder and neck discomfort. Rotation of the head to the right side was limited to 30 degrees, at which point it produced shoulder pain, and rotation to the left side was allowed to be, the patient was able to rotate her head to the left side up to 50 degrees. Neurological testing found the deep tendon reflexes to be +2 bilaterally at the biceps, triceps, and patellar. Sensation was found to be intact. The workup of this patient, several MRIs were obtained. This included a cervical MRI, a lumbar MRI, and a right shoulder MRI. In addition to this, a elbow MRI of the right elbow was obtained. This data is currently not available and will be amended to this report. The MRI that we're currently looking at is a cervical MRI at the level of C2, C3. We can see right here a 2 millimeter focal herniation of the protrusion type, partially effacing the anterior subarachnoid space. At the level of C3 and C4, we can see a broad-based bulge with a protrusion that extends approximately 2 millimeters into the spinal canal, minimally effacing the anterior subarachnoid space. There was no central or foraminal stenosis. At the C4-5 level, there is noted to be minimal hypertrophic changes of the left uncovertebral joint with no noted foraminal stenosis, and there is also minimal anterior spurring seen. It's interesting to note that as we descend the cerebral foramen, the size of them actually decreases, such that C2 to 3 all the way down to C6, 7, there becomes a smaller foraminal space. And this is important clinically because what happens is there's a greater chance for stenosis to occur in the lower areas. So as we begin with the C5, C6 area, our incidence of cervical radiculopathy increases. The probability of cervical radiculopathy occurring in the C5 affecting the C6 nerve root is approximately 25%, and the probability of a cervical radiculopathy that affects the C7 nerve root is approximately 60%. The C5, C6 level, we have a bulge protrusion extending approximately 2.5 millimeters into the spinal canal, affecting the anterior subarachnoid space, mildly encroaching on the lateral recesses. In addition to this, we have hypertrophy of the uncovertebral joints and bilateral foraminal stenosis. The C6, C7 level, which is important to note because it's again a high area of incidence of cervical radiculopathy, shows no evidence of foraminal stenosis, no disc herniation, and no other abnormalities. MRI of the right shoulder was performed to further evaluate this patient. What can be seen here is some hypertrophic changes of the AC joint, in addition to impingement on the rotator cuff. You can see an additional view here. Again, the hypertrophic changes and impingement. MRI also revealed increased signal extending linearly into the base of the superior labrum. This was diagnosed as a grade 1 slap tear. It's a superior labral tail from anterior to posterior. Visualized here as a separation, and also right here. Additionally, there was noted to be increased T2 signal associated with truncation of the anterior labrum. In addition to this, there was tendinopathy of the distal rotator cuff around the area of the supraspinatus. It's visualized here. Here's an additional image. You can see that there has been some tendinopathy and damage in this area. In addition to the MRIs described, electrodiagnostic studies were performed on this patient. Specifically, conduction studies of the right upper extremity were found to be abnormal, and no abnormal conduction velocity of the right ulnar nerve motor fibers was found to localize a conduction block above the area of the elbow. In addition to this, abnormal needle EMG of the right upper limb showed increased insertional activity. This was interpreted as evidence of according to the electromyographer, right ulnar neuropathy with axonal loss affecting motor fibers across the region of the right elbow. And there was noted to be no electrophysiological evidence of cervical radiculopathy, brachial plexopathy, peripheral neuropathy, or myopathy. The interesting aspects in the diagnosis of this patient involved the upper extremity findings. And it's possible that there could have been multiple etiologies, all of which need to be considered. So the top suspects, the ones that were considered strongly, included cervical radiculopathy, in addition to a cubital elbow syndrome. Both of these etiologies are possible to see after an acute injury, such as occurred in this patient when she had her car accident. The cervical radiculopathy is relatively rare. However, it is a cause of upper extremity neurologic neuropathy. The cubital tunnel syndrome is relatively common. It's the second most common neuropathy of the upper extremity, second only to carpal tunnel syndrome. The patient's complaint of upper extremity pain, which was worsened intermittently and associated with tingling, became suspicious for multiple possible diagnoses, including, as said, cubital tunnel syndrome and cervical radiculopathy. The intermittent nature of the distal neurologic findings of the upper extremity were able to be reproduced by applying pressure in the cubital tunnel region. That's the Tinel's sign at the elbow, which is suggestive of the diagnosis of cubital tunnel syndrome. This diagnosis was further supported by the electrodiagnostic studies showing reduced conduction velocity localized to the area above the elbow. Interestingly, the patient also had complaints of upper extremity pain, which is localized to the arm proximal to the elbow, and occurred independently of the intermittent pain which occurred in the distal right upper extremity. Pain in this location had a low likelihood of being caused by cubital tunnel syndrome. In the presence of a positive Sperling's test, again that's the test where the patient rotates the head ipsilateral to the affected side, has a slight degree of extension and pressure from the examiner placed in a caudal position, thereby compressing the foramina, reproducing the painful findings, is consistent with findings of cervical radiculopathy. The patient's cervical MRI provided additional evidence for this diagnosis with the finding of bilateral foraminal stenosis, an encroachment of the osteophyte disc complex on the spinal cord at the level of C5, C6. And as stated before, the foramina become smaller as you become more inferior in the cervical area, with the increased incidence of cervical radiculopathy in these areas. It should be noted that the electrodiagnostic studies were unable to establish any evidence for cervical radiculopathy. These tests, however, have been noted to have poor sensitivity, and the fact that we could not produce electrodiagnostic evidence is not inconsistent with the diagnosis of cervical radiculopathy. The patient's additional complaints of headache, dizziness, neurovegetative symptoms of insomnia, forgetfulness, low energy, poor mood, decreased appetite are all consistent with post-concussive syndrome, which is suspected to have occurred after the incident with the motor vehicle. The patient's neck pain, which is described as localized between her shoulder blades, and her lower back pain were suspected to be secondary to trauma from the motor vehicle accident as well. We see the diagnosis of cervicalgia and acute lumbago. This patient was followed by a chiropractor and additionally referred to surgical evaluation for her cubital tunnel syndrome. Many of her diagnoses were able to be conservatively managed with the use of chiropractic adjustments and medical therapy. This included the recommendation of exercise therapy, avoidance of provocative activities for her cervical radiculopathy, the possibility of attempting cervical traction, use of a cervical pillow or padding, in addition to over-the-counter medications such as NSAIDs like ibuprofen or naproxen for pain relief, the consideration of gabapentin, pregabalin, or amitriptyline for neuropathic pain, and in the event of more severe cases or refractory pain, which did not occur in this patient, injections of corticosteroids or oral corticosteroids, or in very refractory cases, use of opiates like oxycodone could be used to manage pain of her type. In the event of muscle spasm, muscle relaxants like cyclobenzaprine and methocarbamol could be used to provide relief additionally. This patient was also referred for surgical evaluation by a neurosurgeon for her symptoms of cubital tunnel syndrome. This area can generally be evaluated by neurosurgery or orthopedic surgery. In her case, a consideration for surgical intervention was considered because of the fact that she had atrophy of her thenar muscles. This suggests severe impingement of the ulnar nerve and indicates a likely need for surgical intervention. It's possible that mild cases of cubital tunnel syndrome can be treated conservatively, and there is likely improvement of symptoms in the course of months after onset. However, the atrophy and the clear deficit in her grip and pinch strength warranted a surgical evaluation. There are several options for surgery in a patient like this. Proposed surgical interventions for cubital tunnel syndrome include ulnar nerve transposition and ulnar nerve decompression, the choice of which intervention depends mainly on the experience and preference of the surgeon. There's limited research showing that the natural progress of significant cubital tunnel syndrome, as in this patient, is improved with surgery versus non-surgical treatment. However, this is not because of the inadequacy of the procedures, merely because of the lack of research that's been done. Some have suggested that early surgical intervention in the presence of significant impairment, as in this patient, may show improved outcomes. An alternative management strategy used in patients that don't show muscle atrophy, but merely show some sensory loss and weakness, is to treat conservatively for up to 6 months, after which consideration for surgical intervention is appropriate. In patients with less severe symptoms, or symptom onset lasting less than 6 months, conservative therapy consists of splinting, padding, activity modification, and avoidance of provoking factors. In summary of this patient case, interesting findings included upper extremity weakness, tingling, and muscle wasting, which was diagnosed from to be multiple caused etiology, After a motor vehicle incident, the patient was diagnosed with both cervical radiculopathy and cubital tunnel syndrome. Evidence for these diagnoses came chiefly from the clinical exam, MRI imaging, and electrodiagnostic studies. Please see the included handouts for more information on this case and this topic.